We also look at the urine, and the urine tells us whether there is a protein leak. That will give us a clue as to what type of kidney disease is involved. And we look under the microscope for other components like white cells, red cells, and little things called casts, which tell us if there's protein trafficking through the little tubules. We use imaging tests to look at the kidneys, the commonest one being ultrasound, which is a non-invasive test. But there are lots of other imaging tests that we do, ranging from CTs to angiograms to nuclear medicine tests that tell us more about blood flow to the kidney, and you can differentiate between different kinds of kidney disease. And then finally, we have a kidney biopsy, which tells us what specific pathological type of kidney disease we're dealing with. And kidney biopsies are done fairly safely, easily, in the hospital under an imaging study. And the pathologists help us diagnose what we're dealing with. What is chronic kidney disease? How do we define that? Well, the National Kidney Foundation, or NKF, have come up with a terminology. Number one, any sign of kidney damage that persists for more than 3 months designates a diagnosis of chronic kidney disease. And that can be protein in the urine. It can be a structural abnormality that we find on an imaging study. Could be an elevation in the creatinine level. Could be blood coming from the kidney. And secondly, the functional test, so-called GFR, which we mentioned earlier, that's less than 60 mLs per minute. And you'll see on your lab slip that this may be more than 60 or less than 60. If it's less than 60 for more than 3 months, by definition, there is chronic kidney disease, or CKD. What are the commonest causes of CKD? Number one, diabetes mellitus, type 1 and type 2. We are now seeing more and more people affected by type 2 than type 1, especially children. Obesity is an epidemic problem now, so type 2 is definitely taking front stage. And type 2 patients get chronic kidney disease as much as type 1. High blood pressure would be the second one, and often these two coexist, more often than not. And diseases of the blood vessels, or atherosclerosis, can affect the blood vessels of the kidney the same way that they can affect the blood vessels of the heart or any other blood vessel. The third type of kidney disease that we see is called glomerulonephritis, where you get protein and blood in the urine. And there are various types of glomerulonephritis, usually requiring a kidney biopsy to differentiate between one or the other. A hereditary disease called polycystic kidney disease is quite common as well, and this is inherited from parent to child with a 50-50 chance, so-called autosomal dominant, meaning that the gene inheritance would put each offspring at risk of 50%. There's commonly obstruction to the outflow of the kidney, for example, an enlarged prostate in men, or diseases affecting the outflow tracts of the kidney. We have these formulas that I just want to show you very briefly. The commonest one that we now use is the MPRD formula. This is the one that is expressed on your lab slips. It's very commonly used. It's fairly accurate. in stable chronic kidney disease, but there are some flaws to this test, and I'll give you an example in a minute. There is a lot of debate going along right now that we may be over-diagnosing this disease now because of this GFR test that we do. And an example would be somebody with a near normal kidney function test, a creatinine, that spits out a GFR that says that you have stage 3 chronic kidney disease. On the one hand, Dick Glassuk, who's a superstar in nephrology, thinks that this test should be revised or not used because we are labeling too many people with kidney disease. And the second, his opponent, Tom Hofstadter, claims that we are bringing these people to the fore and are able to monitor them more carefully and tell them to avoid to do certain things that may make the kidney function get worse. So we have these opposing opinions about the definition of chronic kidney of the GFR. I'd like to give you an example of a case. I'll take you through it and explain it to you as simply as I can, because this is a very, very common type of problem that we see in our practice. Patient referred with stage 3 kidney disease, and I'm sure my colleagues have seen lots of these patients. Blood test is drawn at a routine visit. It's a 58-year-old healthy woman. And a creatinine comes in at 1.2 here. And the lab sheet spits out a GFR of 48 mLs per minute. And as you'll see in the staging in a little while, this person has stage 3 chronic kidney disease. Bad news. A repeat creatinine was 1.1. The normal is about 0.6 to 1.2. And again, this test looks like there's a problem. So does she have kidney disease? So we usually go through a battery of tests. We look at the urine. The urine is negative. We look at the blood pressure. That's normal. No medications that are likely to do this. So we then can resort to doing that urine collection, the 24-hour urine collection, or creatinine clearance, where you collect all the urine, take a blood test. And what do we find? Well, these are the results, but let me just point out to you at the bottom here that the kidney function in this particular patient is absolutely normal. So you're able to reassure the patient that he or she does not have kidney disease. We know that people who have a lot of muscle mass or eat a lot of muscle, which is meat, produce a lot of creatinine, so that this test can tell that the reason why the creatinine was a little elevated, it could also be because they're producing a lot of creatinine. So this is very reassuring to know that this patient doesn't have kidney disease. Folks in Philadelphia, and if any of you have pens and papers here, you can do this for yourself, a little exercise. Some of the risk factors for kidney disease. This thing flips very easily. This was a study that was put out in 2007. So you can give yourself points and decide whether you have an increased risk of kidney disease. If you're between 50 and 60, you take 2 points, 60 to 73, and so on. Female carries an extra point, I'm not sure why. Anemia, high blood pressure, diabetes, and obvious causes, obvious risk factors. And if you get a score of 4+, you do have a 20% increased risk of chronic kidney disease above the normal population. Still pretty low. Anybody want to play around with this, or should we move on? You don't want to know.
Is that a typo on the first line?
What?
Between 50 and 60.
That was a test. That was 50 and 60. Good for you. This is the classification of chronic kidney disease based on the various stages. Stage 1 and 2, we really hardly ever deal with. The primary care physicians do that, but if the GFR is greater than 90 and there's a little bit of protein in the urine, for example, if perfectly normal kidney function, we're dealing with stage 1, 585.1 on the coding system. Stage 2 is 60 to 89. Stage 3 is 30 to 59. Stage 4 is 15 to 29. And stage 5, that is usually the time that we start one or other form of renal replacement therapy, dialysis, transplantation, and so on. Now, this staging system, again, there are some flaws. People can flip back from one to another based on a minor change in their blood test. But many of our patients know that they're stage 3, they're stage 4, they're stage 2, and hearing, "Doc, what's my stage now?" is a very common question. And we like our patients to have empowered with the knowledge of where they are in terms of their chronic kidney disease. So what do we do at the various stages? We try and slow down the progression of the disease in the very early stages, which is when it will work best. We try and figure out how quickly this thing is progressing. Stage 3 is when we start seeing some of these complications that I'm going to talk about a little later. Stage 4 is when we start preparing for renal replacement therapy, refer for transplant evaluation, get the dialysis shunt in, etc., etc. And stage 5, as I say, is a more advanced stage of stage 5 is when we start getting these folks on dialysis. So what are the first things that I like patients should do? Because this condition is something that patients really need to be empowered about. You need to bond with your treating nephrologist. This person is going to be your priest, your rabbi, your imam, and somebody who's going to be with you for the rest of your life. And hopefully you will establish a good relationship with them, ask them questions, and have them available to be your advocate. Secondly, know your number. What's my creatinine? What's my GFR? What stage am I in? Am I still stage 3? Great. You need to understand some of the diagnostic tests that we do. The test for acid, the test for anemia, the test for calcium, phosphorus. And I'm obviously we're not expecting you to be board certified in this condition, but it is something that the more patients know, the better they're going to cope with it. So become empowered and ask questions. Secondly, the 5, modify risk factors. So any of the risk factors that we can modify to slow down progression, and also to prevent one of the major complications of kidney disease, cardiovascular disease, is most important. I'm going to talk some more about this a little later. And then, as I said before, we want to slow the progression of this disease, if not stop it. So what are the modifiable risk factors? Number 1, number 2, number 3, number 4, hypertension. And there are very definite guidelines about what blood pressure should be in patients with chronic kidney disease. Basically, the lower the better. The current recommendation is 130/80 or less, but if in certain circumstances, diabetes, protein in the urine, we would like it less than that. We have to treat the underlying disease. It's no point treating high blood pressure and letting the diabetes be rampant. So diabetes control is crucial. Lupus, any disease that is underlying this condition, we have to treat as well. ACE inhibitors and ARBs, or angiotensin receptors, are the hallmark of treating patients with chronic kidney disease, both to control blood pressure as well as to slow progression. And these are drugs that are used commonly and is the first line of therapy, recommended therapy in treating hypertension in chronic kidney disease. Now, some folks cannot tolerate ACE inhibitors, lisinopril, drugs like that, which they call the cough. And then we revert to the ARBs, and sometimes we even use a combination in certain circumstances. And especially in diabetes control, we like to use these agents. Proteinuria, protein in the urine itself, is recognized as a significant risk factor for cardiovascular disease later in life. So these drugs as well reduce the protein losses in the kidney. So we try and minimize the protein loss to less than 500 to 1,000 milligrams a day or less. In diabetes particularly, especially in the early stages of diabetes, when you start to leak just a little bit of albumin, this is the stage when these drugs are crucial. And if you get this diabetes in the early stages of diabetic kidney disease, you can halt and reverse it. And using a combination of these agents and others, we can certainly stop this disease progressing for many, many years. Treating anemia is thought to slow down progression of kidney disease. So we'll talk about the various types of treatment of anemia. We know that cigarette smoking is a risk factor for chronic kidney disease. I don't think there are too many people in Palo Alto smoking cigarettes. And there's certain drugs that we like to avoid. Number one, the anti-inflammatory agents, ibuprofen, Advil, Vioxx, any of them taken over prolonged periods of time and in large quantities can and will cause progression of kidney disease. I think some of you may have seen the ad on television about this lawyer in Florida looking for cases of Fleet's enema or Fleet's phosphosoda toxicity. Well, sodium phosphate solution used to be used quite commonly in preparing people for colonoscopy. We have seen patients in our practice with irreversible kidney failure from this substance, taken orally in excessive doses. The higher risk one would be the oral solution, but the enema solution, which is available over the counter, is also risky. So you should make sure that if you have to have a colonoscopy and you do have any degree of kidney disease, you should get the big bottle, the polyethylene glycol solution. And you go lightly, it's pretty horrible stuff, but it's safe. This substance, gadolinium, is a substance that we use when we do MRI studies using a dye, so-called MRA or MR angiogram. We now know that people with kidney disease exposed to this stuff do have a small but measurable risk of getting a devastating disease called nephrogenic fibrosing dermopathy. It's a devastating condition of the skin, and the radiologists are now quite familiar with this, and they will screen patients with any form of kidney disease. We know that obesity is a risk factor for progression of kidney disease for various reasons. I've put diet in here, and it's important to know that certain aspects, and I'm going to spend quite a bit of time talking about diet because this is a very important topic, especially important in diabetes. We'll talk a little bit about protein in the diet, salt in the diet, and phosphorus. Cholesterol and triglyceride management, there's some evidence that patients with uncontrolled lipid levels can get more rapid progression. We don't know whether treating it makes a difference, but certainly the statins like Lipitor and Zocor, which I'm sure most of you have heard of, do have other important anti-inflammatory properties that we think may slow down kidney disease as well. Family history. If you have a first-degree relative with any form of chronic kidney disease, you are at increased risk of kidney disease. Exercise may be a factor that will help slow progression. Obviously, genetic counseling can prevent kidney disease. And let's talk about some of the complications. Firstly, anemia. I mentioned earlier that the kidneys make a hormone called EPO. Are you all familiar with EPO? EPO is the stuff that the Tour de France guys dope themselves with. It's a chemical that stimulates the bone marrow to make red blood corpuscles. So erythropoietin is manufactured in the kidney, and some years ago, a company by the name of Amgen, I'm sure you've heard of Amgen, manufactured this in the lab with genetic engineering. And we've had this around for, what, 15, 20 years now, 15 years maybe. And it's a remarkable drug. It's reversed the management of anemia tremendously. And I can remember when we used to transfuse patients regularly, resulting in hepatitis and iron overload, and we hardly ever have to transfuse patients anymore. So when patients get to stage 3 and beyond, anemia is not uncommon. And we have guidelines of treating patients with anemia for this to get the hemoglobins up, but it's partial correction. We do not want patients to get their hemoglobins back up to normal levels of 14 or 15, because it was shown in these 2 studies here, the CHOIR and CREATE trials, that these patients actually did worse from certain aspects, cardiovascular aspects. Very expensive is Epogen and Aranesp, which are both manufactured by Amgen, and we generally use one or the other, and it's given on a regular basis under the skin like insulin. Patients on Medicare get it paid by Medicare, and most insurance companies will cover it. So as I mentioned, we target the hemoglobin between 10 and 12. Normal for a female would be 12 and 13, and for males a little higher. So we do not exceed 13. We know that it improves quality of life. Patients do generally feel more energetic, not always. And as I mentioned, you have to be stage 3 or beyond. That's erythropoietin. There are new products coming out along this line, but this is what we're using currently. High blood pressure, very, very important. We know that you can slow progression significantly by getting blood pressure down within the recommended guidelines. And we also know that for the same degree of blood pressure lowering, these drugs, the ACE inhibitor and the ARB, will slow progression more than other blood pressure medications. We also know that it will reduce other cardiovascular risk factors like heart attack, stroke, and an enlarged heart, or so-called LVH, left ventricular hypertrophy. It's very, very rare that we can control blood pressure with one drug, and more often we see people needing 2, 3, 4, even 5 drugs with different mechanism actions to get our goal. So that's hypertension. As I mentioned to you earlier, one of the most serious complications of chronic kidney disease is cardiovascular disease. Patients who start off in stage 1 and progress are more likely to have problems with cardiovascular disease than need dialysis. A minority of patients starting with chronic kidney disease will end up on a kidney machine or with a transplant. But more importantly, they will have to deal with one or other form of cardiac disease, cardiovascular disease. So major risk factor, like high cholesterol, like family history, like uncontrolled hypertension, chronic kidney disease is now recognized as a major risk factor. And we know that there's a lot of calcification that takes place in these patients, in blood vessels throughout the body. So I mentioned the traditional risk factors. There are other risk factors called oxidative stress and so on. I'm not going to go into that. So as I mentioned, more patients will have problems with cardiovascular disease than will need dialysis. So as many risk factors that you can modify, you should do because of the impact on cardiac disease. There's a very unique form of calcification in blood vessels that occurs. It happens more in the wall than in the inner lining of the blood vessels. It may be related to calcium and phosphorus in the body. It's more common in diabetes, and it can affect all blood vessels. We also have to deal with bone conditions, and the kidney, as I mentioned, is a very, very important activator of vitamin D, which interacts with another hormone called PTH, or parathyroid hormone. The parathyroid glands are 4 glands that are situated in the neck, and they make a chemical called PTH. And we know that quite early on in the progression of kidney disease, the PTH levels start to creep up in order to eliminate phosphorus that tends to accumulate. So there are different kinds of bone problems. We know that there's an increased risk of bone fractures in patients with chronic kidney disease. And there's a stepwise approach to managing this. We try and eliminate phosphorus, reduce it, can't eliminate it. And I've given you some handouts about phosphorus at the back there. I'm not sure if there are any left. So as the kidney function declines, we try and reduce the phosphorus intake proportionately to the amount of decline in kidney function. And we like patients to work with dietitians, get guidelines on phosphate reduction. We use different types of vitamin D. Many patients with chronic kidney disease, and many other patients as well, have vitamin D deficiency. Our dermatologists tell us to stay out of the sun because we can get skin cancer. So we do, and we get vitamin D deficient. And then this is the basic form of vitamin D that comes through that gets activated in the skin and the liver, and then the kidney activates it. Now, when the kidney is not working properly, you have low levels of activated vitamin D, and that stimulates this neck hormone, the PTH, to kick in. So when we start seeing this level going up, we're also able to give you active vitamin D, so-called 125 vitamin D, to suppress the PTH levels and protect the bones. And we also monitor the calcium and phosphorus levels. So how often do you need to see your kidney doctor? Depends on the stage. In the early stages, maybe once a year. And as the condition progresses to every 6 months, 3 months, and as we get to the stages of early stage 5, we like to see you once a month. Patient groups, not a very common entity around here. We like to have patients counseled about how to prepare themselves for kidney replacement therapy. We like to have them have them have nutritional counseling. Very important when they get to the later stage of kidney disease, what their options are in terms of doing one form of dialysis versus another form versus transplant, and quite frankly, not doing anything at all. Oftentimes, psychological counseling is necessary. We monitor the labs, usually in preparation for the doctor's visit. And after 6 months of torture, I love EPIC, the current computer system that we have. And we also manage the anemia and manage the iron stores. Because as the red cells are produced in more quantities, the patients can get iron deficient. Most patients are followed by their primary care physician, and the question is, when should they be referred to a nephrologist? Well, there are some guidelines on that. These are the current guidelines that were published in 2002. In general, when the primary care is unable to prepare an action plan, is unable to carry out planned evaluation, or if the patient is unable to carry out recommended treatment. That's the official guidelines. In general, when the GFR is less than 30, I think that's too late. Generally, we've seen patients much earlier now, fortunately. So, if we get to the later stages of kidney disease, preparations for RRT, renal replacement therapy. Most important is options education. And this is a partnership between the physician, the dialysis nurse, the social worker, the dietitian, the patient, and the family, looking at the various options, visiting dialysis clinics, and trying to decide which they think is best suited for their lifestyle. There are some studies that show that a life plan is maybe better, that is looking at moving from one modality to another and thinking about the possibilities of starting with one and then getting a transplant. And there have been some studies done by Devons et al. That if you do this transition points and integrated care, you can save a lot of money in the care of the patient. Very, very expensive business, this taking care of patients on dialysis. These are thousands of dollars a year. If the patient is thinking of going on to hemodialysis, that's blood dialysis, in the stage 4, we need to make the preparation for getting access to their circulation, which is usually a fistula or a shunt. A fistula is simply a junction between an artery and a vein. It's a relatively simple operation. And we try and protect the non-dominant arm, which is usually the left arm in most patients, from any needle sticks and IVs, so that the veins are preserved and that the vascular surgeon can find a good vein either by inspecting the arm or by using a Doppler technique to try and find a vein. Home therapy. This may be the best option for many patients, simply training the patients to do their own dialysis at home. It may not be the best options for others, and there's no strict rules about who is or who isn't suitable for this. There are some general contraindications to doing this, but most patients are suitable to do home therapy. And there are different kinds of home therapy. After attending the options class, interviewing the patient and the nephrologist, the commonest type of home therapy is so-called peritoneal dialysis. And the peritoneum is the lining membrane inside the abdomen, which surrounds the intestine and simply acts like a semi-permeable membrane across which the toxins can diffuse and are easily accessible to drain outside of the body. This can be done with a machine, a cycling machine that's plugged in and programmed when the patients go to sleep, and it does the treatment during the night, and that's that. There's also now a form of hemodialysis or blood dialysis, which is receiving quite a lot of attention, so-called nocturnal dialysis, which is a very, very slow process that goes over 8 hours. And our patients who are doing this are doing remarkably well. And it may be that this may turn out to be the best form of dialysis that may become available. Peritoneal dialysis is usually underutilized for various reasons, mainly because the patients are not properly informed about it. Many physicians, many nephrologists are a little less comfortable with it for so-called physician bias. So it's critical for the patients to be part of the decision-making tree in terms of what they think that they would do best with. The commonest form of dialysis is where the patients come into a clinic simply 3 times a week, and most of you have a neighborhood dialysis clinic. There are many clinics around, and you simply come in. Usually it's a Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, Treatments average about 3 hours, and it's usually not uncomfortable by any means. Transplantation is probably the best form of therapy that we have available. It offers a cure, and the problem is that there's a tremendous shortage of kidneys in terms of deceased donors giving kidneys. Your driver's license, that little pink dot, very important. Patients can go on the waiting list when the GFR, now you're all experts in GFR, when it's about 20. And there's a waiting list system that's governed by a body called UNOS, which supervises that no one jumps the line. There are different kinds of transplants. There's obviously deceased donors, and then there's living donors who donate one of their kidneys. And we know that people who give one kidney away have a perfectly normal life expectancy. There are excellent studies to show that. And you can be living, ideally an identical twin. So if you have an identical twin, please be very nice to them, especially if they're kidneys. They can be brothers, sisters, any relative. And then more commonly now we're seeing non-related living donors, spouses. I've had people's lecturers, professors giving them a kidney, friends. And there's a strange donor called an altruistic donor, and a donor who doesn't know the person who's getting it. We screen those pretty carefully. Unfortunately, the waiting list, as probably most of you know, is extraordinarily long in this area. It's about 5 to 7 years to wait for a kidney. So you're looking at a large waiting list. And so there is this little program called the Extended Donor Program for old folks like me who want a kidney, who probably don't have 40 years ahead. And we will take or consider taking a slightly less desirable kidney, perhaps from an older donor. Very successful program that's being done. And I think you may have heard of this one called the Donor Swap Program. For example, a brother and a sister or a spouse who wants to give their partner a kidney and they're incompatible. So we do a computer modeling and we line up 2, 3, 4, 5. I had a couple go for a 6-couple donor swap and domino type thing. This was done at Johns Hopkins, where it's been perfected. And this is becoming a very popular, or very interesting program. Usually if the blood group, the ABO group, either A or B or O, if there's incompatibility, we used to not transplant across that incompatibility. That's changing as well. And we are now doing ABO incompatible transplants with a fairly complicated immune modulating program. And so transplantation is really the preferred form of therapy. Now stage 5, I just want to spend a little bit of time talking about stage 5. It doesn't necessarily mean you have to start dialysis. There's lack of evidence that supports that as soon as you hit stage 5, you need to start dialysis immediately. If the complications are managed carefully, the patient is seen frequently, we can hold off dialysis for a significant period of time. Provided that you are prepared to start dialysis, they should have a shunt in vascular access in place, and things can change. I just wanted to spend a few minutes talking about diet. One of the common questions when I see a patient for the first time is, what can I do to stop this or slow this down? Well, one of the things, the most important things would be blood pressure control, and diabetes and so on. But what about diet? And diet is a very common question. Can I stop or reverse this disease with diet? And this question has been looked at in detail. There have been a number of studies trying to figure out whether reducing the protein intake in the diet can slow this disease down. The most important study being what was called the MDRD study, which looked at it for over 2 years, putting patients on a normal protein diet and a low protein diet. And then there were 2 extensions for another 6 years each, so a total of about 14 years of follow-up. Many other studies were looked at, and some are contradictory, some are not. And the bottom line is that we think that we can make a small change to some patients by modifying their diet to reduce the protein intake. And I've put some instructions, some information out there about protein restriction. And we usually guide our protein intake by the body weight of the patient and so many grams of protein per body weight. We also feel that reducing the phosphorus intake, reducing the salt intake, especially in patients with high blood pressure, is very important. So the bottom line is that we think that dietary management plays a role, probably a small role, but it's not entirely clear whether it's additive to the other things that we do using those drugs, the ACE inhibitors, the ARBs, and so on. We don't know the answer to that question. So the current recommendation is, yeah, you probably should try it. Possibly more important in diabetic patients. There are some diets out there, ultra low protein diets, which have been proposed by people like Mackenzie Walser in Johns Hopkins. Very, very low protein diet, a miserable diet, but supplemented with things called keto acids to prevent protein wasting. Currently, there are very few people who are proposing this form of therapy. It's a brutal diet, and quality of life does come into it as well. So, how are we doing? Oh, time flies when you're having fun. Support systems are very important. I'm just going to have you skim through that. There are lots and lots of information. You can Google lots of information. There's a National Kidney Foundation website that has a tremendous amount of information. So, chronic kidney disease is a chronic, long-lasting condition that is best treated by a capable and caring team in partnership with an informed and educated patient or advocate. Most people with CKD that's a typo. They are able to live long, healthy, and normal lives. It is absolutely essential to be fully informed at all stages, develop a life plan, and with all of this stuff, we can try and stay one step ahead of the game. Thank you very much.